Hey everyone, my name is Warren Weekman. I am the course director for the Health 2.0 and Digital Literacy course that we're running out of the UC Irvine School of Medicine. Now, initially, we wanted to do these sessions as simulcasts, but we had some technical difficulty on our first block, so we're doing the first session of 8 as a podcast, and we're posting it up here on our website. So we apologize for that inconvenience. I know a lot of you were looking forward to seeing the first lecture, and we apologize for that delay. The next 7 series we hope to do as simulcasts, one each month for the next 7 months, but we will have them available also as podcasts for viewing later on. So we hope you enjoy the course. We put a lot of time into making this as helpful and as informative as possible for medical students, residents, and faculty, and we hope that you get engaged in the discussion, and we hope that you take some time to check out the website, get involved in some of the online discussion. If you want to contribute, if you want to learn more, if you want to exchange ideas with us, please reach out to my group through the website, and we look forward to hearing from you. And as I said before, enjoy the course, and thanks for your time. All right, here we go. Well, hello and welcome everyone to the Health 2.0 and Digital Literacy course. My name is Warren Weekman, and we're going to go through an overview today of what this whole course is designed to be, this and the next 7 sessions. Give you a little bit of overview of what we're talking about when we say things like Health 2.0, when we talk about digital literacy, give you a little overview of what the course is going to entail over the next 7 sessions after this, and then talk a little bit about the field of infographics and information design and why that could be a good sort of building point for what we're going to talk about over this course. And as the course goes through, I want to give you sort of 3 kind of buzzwords to keep in mind as we're going through this. I want you to keep in mind the question of context. I want you to think about engagement and empowerment, because those are 3 big themes of what we're going to be talking about both today and throughout the course. And they'll kind of help frame a lot of this discussion that hopefully we're going to be having here both in the room and online. So first off, I want you to do a little exercise for me and think all the way back 3 years ago to 2009. So for those of you that need a little help thinking back that far, you can think about movies that were popular. The Hangover had just come out. Avatar was just released. For you Twilight fans, New Moon was released in that November. Big events in the news. We had the U.S. Airways Flight 1549 landing in the Hudson with Captain Sully Sullenberger doing that amazing landing there. You can see the photo from one of the different news outlets posted up on Wikipedia. Other big events were the inauguration of Barack Obama early in that year. When we look at medically what was going on that year, you have the swine flu outbreak and epidemic. If you think about it, if you're traveling at that time, there's all the questions about body heat sensors in airports, Tamiflu shortages, families very, very concerned. I don't know if you remember, though, they did find the source of that outbreak, and they posted that up on many, many sites, for the source of what was causing this big swine flu epidemic. And when you think about technology, at that point in time, for all of you Apple fans, there had just released the iPhone 3GS, the improved video functionality there, faster processor, all of the other incremental improvements with the iOS platform. Again, August 2009, there wasn't really a tablet out there in the sense that we know it today. There were e-readers that were present, but no real tablet format. And so a lot has changed, technology-wise, thinking back to 2009. Clinically, we didn't really have full integration of the EMR at that point. A lot of you who are med students right now probably weren't in any sort of clinical experience, weren't in any sort of medical school exposure at that time, so I'll talk a little bit about what I was doing at that time. At that point, I was a third-year resident, my last year residency in emergency medicine at the UC Irvine School of Medicine, Department of Emergency Medicine. That's me over here, second from the right on that photo. And as I mentioned before, when we started out our residency training, there was still a lot of paper-based systems. We had computerized order entry through a system called TDS. Now, this is, of course, not English. We did have the English pack, which was very nice, made ordering a lot easier compared to this. But as you can see, it's not the best user interface screen. It's actually more like a DOS-based, kind of text-based system that we used for order entry almost throughout my entire residency. We didn't have any patient tracking systems. Our patient tracking board was actually a physical whiteboard where we wrote names on the board. We had physical charts that were placed in a rack for patients next to be seen. And over the 3 years of my residency up till 2009, we'd made some incremental improvements, and we'd started exploring and playing around with the early stages of a full EMR, but the transition was still pretty slow, and a lot of our other clinical sites weren't even quite there just yet. So I want you to fast forward a little bit back to current times, thinking about 2012, thinking about right now. Fortunately, we don't have to go through too many of the current events, but just let's take a look at where technology is today as far as what we're going to talk about in this whole Health 2.0 discussion. We have the new iPad out this year. Also, you have things like the iPhone 5 up from the 3GS. You have a litany of both tablets now, with the Google platform. Other tablets have sort of come and emerged in the market. E-readers are now kind of branching out from just e-readers to sort of tablet e-reader hybrids like the Kindle Fire. You have a huge number of smartphones. Windows is making a resurgence in the mobile platform. So kind of the options for technology have almost exponentially increased since 2009. And when you think about medical schools as far as how that relates to this discussion, we started our iPad program in August of 2010. And at that point, there was just a very small handful of us doing these sort of pilots. And since then, over the past 3 years, we've gone from a handful of programs up to 34 programs throughout the US and Canada that have an iPad or tablet-based program within their medical school curriculum. Now, there's 155 programs in the AAMC, which is the Association of American Medical Colleges. And so these 34 programs represent about 20% of the medical schools out there that are experimenting or have very established mobile technology-based curriculums. And it's not just limited to the US. We're starting to see an emergence of programs internationally, and we're trying to team and pool our resources with them. A couple of great programs in University of New England in Armidale, Australia, University of Newcastle in Armidale, both leading the way in Australia for mobile technology. Programs in Japan, programs in the UK. Again, not a full list. There's just a lot to keep track of, but these are kind of hot spots of where technology is being used in the medical curriculums that we should all keep our eye on. So now I want you to think about, that was just 3 years. And there's been a lot of change in those 3 years. So think about what happens when you graduate from medical school, 2015 or so. What are things going to be like then? What's technology going to be like then? What's technology going to be able to let you do in both your studies and clinically in 2015? And then take that one step further. Think about when you're finished with your residency training. Think about when you're starting to practice or doing a fellowship or actually have been out for a couple of years. Think about 2020. What is that going to be like as far as technology and healthcare and patient care and education? It's going to be a whole different ballpark. I think it's kind of hard to even imagine what things will be like in 2020 because of the huge leaps and bounds that we've made from just 2009 up to 2012. So a lot of the times, this is going to be a big question of context. What is technology going to help us do? What's technology's role going to be? And so specifically, when you think about, what is that role of technology going to play in the healthcare setting? Are these two things over the next 5, 10, 15 years going to develop in parallel as we move forward? Or is it going to really be a close sort of assimilation of the two? Are they going to work together? Or is it going to be a very close integration, bonding, and then moving forward? So if that's going to be the case, if these two things aren't going to move in parallel, but really work together as an integrated system, what does that mean for us as medical educators? What does that mean for us as we're trying to educate you as students and residents to become better physicians and modern physicians? How is that going to affect what we do? And so when you think about healthcare technology, we're really good at teaching, healthcare. And we're really good at teaching health. We're really good at teaching medicine. We're trying to branch out and teach proactive health, all those different things. But none of us have really thought about how we're going to teach technology. Or even, I guess more importantly, should we even teach technology? It seems like such a moving target. Why should we even bother teaching that? And so to put it in perspective, we asked some of our students just informally over the past couple of years, what their familiarity with some of these concepts were. How many EMRs have you been trained on? How many PACS systems or radiology systems have you been trained on? And at UC Irvine, the way our hospital system is set up, our students rotate through 3, maybe even 4 different clinical sites. And for each one of those clinical sites, they have to use a different EMR to access patient records. So by the time they hit their 3rd year or into their 3rd year, they need to be responsible for knowing about 3 or 4 different electronic medical record systems, as well as PACS systems. When we ask questions about phone or iPad HIPAA compliance, we'll talk about that in a little bit. Even things like, would you recommend Diabetes Mine or Chronology or even 23andMe to your patients? And a lot of our students don't know what any of these things are. Now, these sites, the first 2, Diabetes Mine and Chronology, are kind of social media communities built by patients that address the needs and the day-to-day intricacies of living with these chronic diseases like diabetes, like Crohn's disease. And they spend a lot of time kind of getting people together and sharing their experiences. As one of the people who helped put Chronology together, I think their founder, I heard him speak about the site, and he was saying, I've got a lifelong experience with Crohn's disease. It's a shame for me to not be able to share that with someone who's just recently been diagnosed. He's learned so much throughout his life of how to manage his Crohn's beyond just the medication. He wanted to find a way that he could share that experience and help others who were just starting that journey. And a lot of these sites are built on that. There's a lot beyond just medications and testing and checkups with PMDs or specialists for these diseases. There's a lot of lifestyle issues. What restaurants are good? What are recommendations for foods and diet and other items that even the specialist may not be able to help with, but someone who lives with that disease day in and day out could probably be very, very helpful. And these sites create a community for people with those diseases to share and kind of help each other out, which is great. 23andMe is a personal genomics service where you can submit a swab for a fee, then they run a genetic profile and a pharmacogenetic profile and kind of compare your risks for certain genetic diseases and responses to medications, so you can be more informed about lifestyle and just what you're potentially predisposed to, and if you can make impacts on your health before those changes become more evident. On the bottom, we asked our students, are you familiar with these devices at all? These are kind of devices that represent part of the quantitative self movement. These are personal kind of tracking, calorie activity trackers. This is the Body Media armband, the Nike Fuel Band, and the Fitbit. And they all work either wirelessly or through a USB. Keep track of your activity data, sleep data, steps, calories burned, and provide real-time feedback. So if you're trying to lead a healthier lifestyle, you can use that data to make smarter choices. And finally, for those of you on Twitter, the hashtag HCSM is healthcare and social media. And there's a lot of our students that, even though they're relatively tech savvy, haven't really experimented much with social media or Twitter, or have not even really seen the potential, and of course there's also pitfalls too, of what social media could do in a healthcare setting. So, when I talk about HIPAA compliance, kind of asking more and more about these kind of questions to our students, these are some of the results that we got from a simple questionnaire, that they feel comfortable that their devices are HIPAA compliant, overall pretty good, but there's still, 25, 19, 36% of students that feel, they disagree or feel very unsure about their HIPAA standings on their devices. Take that a little bit further for things that they should even be more familiar with, such as email and USB drives, and there's still a large percentage here that don't feel comfortable with these security precautions. And again, these aren't sort of future state things that I'm talking about. These are email and USB drives have been around for quite a while. HIPAA's been around for quite a while. And still, at this point, these are clinical students who are 3 years into medical school. They still aren't sure if they're meeting guidelines. So that right there, even without any of this other stuff as far as tablets and mobile technology, that tells me right there that we are not doing a good job at all as far as educating our students as far as safe practices in a modern healthcare setting. And so when we talk about this further, here are more things that the students are being faced with that they have really no concept of at this point. Insurers embracing virtual doctor's visits. There's this whole field of telemedicine, telehealth that's happening right now. Discussions are happening with insurance companies about reimbursement, and our students really have no concept of these things just yet. Or even, you talk about smartphones and mobile devices, can they do more than just act as reference tools and patient care devices? There are all these different apps for special needs children's, interpreter apps, finding ways to give a voice to patients who normally have not had a voice, and we're not even really preparing our students to think about how we can help these patient populations out. And probably the most important part of all of this technology piece with EMRs, there's a lot of discussion going on about, is technology, interfering with this physician-patient interaction. And, there's a lot of criticism for EMRs and bedside technology kind of dehumanizing that patient-physician relationship. And even some have advocated that it's now a three-way relationship between the patient, physician, and the device. And how do you teach that interaction? Does it make sense to teach our students how to interview a patient and then go back and take notes on paper or do a paper chart when in 3 or 4 years they're never going to touch a piece of paper and pencil in a clinical care setting? Is it appropriate for us to then instead teach them how to interview a patient, maintain that relationship while using a tablet or a laptop or a workstation to enter that data or look up data? I'll let you think about that for a little bit. So when we ask that question again, as far as technology and the role of what it's going to do in a clinical setting, we got these kind of results here. When you look at the iPad being a distraction or being a benefit in the clinical environment, when we think about distraction, there's still 4 to 3% of our students who have had iPads already for 3 years that worry that it could be a distraction to them in a clinical environment. Whereas almost 97% of them think that it's going to be very, very useful. So how do you mitigate that combination of usefulness in the setting of possible distraction? And you ask other questions too, as far as, what's the impression going to be of me and my device? Patients will have a favorable impression. Most students feel that way. But there's still 14% that are concerned that the patients might think they're playing Angry Birds in the back of the room. Same with faculty. You're trying to, while providing good patient care as a student, what you're really trying to do is impress faculty to hopefully get a good grade, to learn a lot, to maybe progress clinically, and maybe even kind of secure yourself a spot in a good residency training program. And there's still 14-15% in both groups that worry that the iPad may have negative connotations. So what do we do about that? We can't just not have devices. We can't just not have technology at the bedside. How do we address these concerns? So what you have to do is teach the right way to do these kind of things. And at UCI, you guys are very familiar with this. We're doing these sort of simulated sessions in our OSCE exams, in our patient encounter, our simulated patient encounters. But what we're doing now is actually testing students on how they use technology at the bedside. So we're asking them to put together a little teaching module for the patients, for the standardized patients, and they get graded on how well they can teach to a patient, how well they can introduce the technology to the patient, and how that interferes or complements their interaction with that patient. What we've done at UC Irvine as well is put together this mobile technology etiquette checklist. Again, we'll have links up on the website for this. It's our sort of 15 questions that you need to ask yourself before you go into a patient encounter that'll help you prepare better of how to use your technology at the bedside. So, as you can see, there's a lot of things changing here in medicine. From the picture shown, this is an 18th century physician doing a bleeding of a patient, which at the time was considered, cutting edge medical science. And as we've talked about so far in this discussion, medicine is evolving very, very rapidly. And we're talking about in terms of months and years, not necessarily decades like we were talking about beforehand. And therefore, medical education has to evolve if we really want to prepare our students, such as yourself, to become, adequate and competent modern physicians. And so you sort of have to ask yourself, are you on track to becoming a digital physician of the 21st century? And I'm not necessarily talking about just, email and logging into an EMR. Those are almost like 20th century concepts. We're talking about, interactivity involving patients in their care, personalized medicine, genomics, social media, social networking, crowdsourcing, all of these different concepts. You need to ask yourself, within your medical education, within your medical training, are you being prepared to become that true digital physician?